We want to welcome you back to We Got Your Number podcast. And we're speaking with Cameron Rokhsar, a good friend of mine for many, many years, world-class dermatologist. We'll get a little more medical on this one. Allie got to ask you some fun questions. We're just going to ask you some things. When we're in med school, they talk about skin, and they talk about skin being the largest organ that there is. And people go, well, it's not the heart or it's not the liver. I mean, how does the skin be an organ?
Well, the skin is an organ because it has certain functions and it's got its own blood supply. Uh, some of the important function of the skin is the skin barrier, which it prevents the outside world to come inside, right? So whether that be chemicals, whether that be infections, whether it be microorganisms, the skin also kind of is a living organ. It's got its own blood supply. It's got arteries, it's got veins, it's got sweat glands, it's got hair follicles, it's got its own system of lubrication in terms of oil glands or sebaceous glands. It's got nerve endings. So, it has function and it's got form and it's got its own kind of ecosystem.
Well, the whole study, dermatology is the study of the skin, the activity of the skin. So it's got to be incredibly much more in depth than just thinking about the superficial things that we think about skin and all that. So getting in a little deeper, a little medical in, let's talk about skin cancers. Why you get them, what kind of the treatment modalities, have that changed? How often should people get examined, their body check for moles? What's the standard on that today?
So, Tom, as you well know, skin cancer is actually the most common cancer that people encounter. Now, there are three main forms of skin cancer, and the most common one being the basal cell carcinoma, the second most common one being a squamous cell carcinoma, and lastly, the very serious one, melanoma. So let's kind of delve into each one.
Okay.
The basal cell carcinomas are cancers of the basal layer of the epidermis. So, we have the skin has the epidermis, it's got dermis, the epidermis has cells, the dermis has basement membrane proteins and blood vessels and sweat glands and oil glands and hair follicles, and then you've got fat underneath. So basal cell carcinomas are cancers of the basal layer of the skin. Basal cell carcinomas are usually locally destructive, so they can cause a lot of damage to local tissue, but normally they don't invade lymph nodes or other various organs. But they could be destructive to major anatomic features of the face, including, let's say, eyelids, the nose, the ears. You can eat away at your tissue. Squamous cell carcinomas are cancers of the entire epithelium of the epidermis. And so squamous cell carcinomas can be a bit more dangerous. They potentially do have the capacity to invade lymph nodes and go to various organ systems. So they can affect facial lymph nodes. A very common areas where skin cancers can do that are scalp skin cancers in men on their head, ear skin cancers, and also lip cancers, because those squamous cell carcinomas on those areas could be particularly aggressive. Lastly, melanomas. Melanomas are the cancers of the melanocytes. Melanocytes are the cells in the skin that give pigment to our skin. They produce melanin.
Correct.
And so melanocytes in large congregations are found in moles. Moles have melanocytes. Now, melanoma is the cancer of the moles or the melanocytes. Melanoma has a high capacity to be able to invade lymph nodes, and also it can go to lungs, brain, bone. So it can be a very deadly, aggressive skin cancer that particularly kills young people. The average age of a melanoma patient is 29 years old, and it affects women more commonly than men.
Okay.
So in terms of treatment modalities, so basal cell carcinomas are usually treated with surgery, whether it be a surgical excision, We also do what's called Mohs micrographic surgery, which is considered the most precise form to remove a skin cancer with the highest cure rates of 98 to 99%. Mohs surgery involves us cutting the tissue and doing frozen section examination of the tissue right in our own lab as we're doing the surgery to make sure both the deep and the peripheral margins are clear.
Now there's some advertising I see for something called gentle laser, which is, I guess, radiation therapy for basal cell carcinomas. Is that?
So I and most of my colleagues believe that radiation should be saved as a last resort. Radiation is never first line therapy in treatment of any cancer, as you know. It's always surgery because surgery is a definitive cure. The radiation is always reserved for people, A, who cannot undergo surgery for various medical problems, B, for cancers that have failed surgery. Yeah, that's not
Yeah,
the
that's
bad.
yeah.
Yeah, those are the
of
main
course.
things, really. Yeah, I actually had a C in mind and it just escaped me.
Yeah.
It's
Well, surgical intervention and then
so locally
radiation
inoperable.
as for cure.
Locally
Yeah,
exactly.
yeah.
Oh, and third, as an adjuvant to treatment of aggressive cancers, right? So, for example, aggressive squamous cell carcinomas with a certain grade, we do surgery and then we do also radiation at the base.
Absolutely,
Right?
as
So
a planned procedure.
correct.
Yeah.
So, but I believe most of my colleagues will not agree to the idea that radiation should be used as first line therapy. Now, squamous cell carcinoma is also treated the same way, either surgical excision or Mohs micrographic surgery. And melanomas are generally treated with wide surgical excision. And kind of the treatment plan depends on the depth of the melanoma, something called the Breslow skin thickness or the dermal thickness.
Correct.
Obviously, the deeper the melanoma, the more extensive the treatment plan becomes and the more arduous it becomes.
Because a melanoma can metastasize, and so you have to worry about the deeper it is, the more it has capability of going to a gland and metastasizing. So
Correct. And
you have to be more aggressive with it.
those are particularly worrisome in melanomas that are 4 millimeters deep. So those are called extremely deep melanomas, Breslow thickness of 4 millimeters and deeper. Almost always you have to do surgical excision plus a sentinel lymph node biopsy. A sentinel lymph node biopsy is a procedure where you actually inject dye as well as radioactive isotopes to isolate the draining nodes in a particular area of the melanoma was to investigate the degree of involvement or the number of involvement of the draining lymph nodes,
Yeah.
and then come up with a plan according to that information.
So how often should people go for checks for moles?
So the American Academy of Dermatology recommends that every patient have a thorough skin check by a board certified dermatologist at least once a year. If you've had skin cancers, you may have to increase that frequency. For example, studies have shown that you have a 50% chance of developing another skin cancer once you've had a basal cell or squamous cell carcinoma. So the odds are against you, especially if you're younger. That means that your skin has incurred a certain amount of ultraviolet radiation where the DNA of those cells have really gone berserk. So for those patients, I recommend to be checked at least twice a year. Now, for melanoma patients, the recommendation is different. So if you've had history of melanoma yourself, the first 2 years, you need to be checked every 3 months and then every 6 months for the rest of your life. But you also must have your first degree relatives. That's your children, brothers and sisters and parents be checked at least once a year because we're discovering that there's many genes now that are being implicated in melanoma.
Let's talk a little bit about the aging face, changes that occur. They're occurring in the epidermis, the dermis, the sub-Q. Where are those changes occurring, and how are you affecting those?
Okay. So I like to think of the aging face as two main components. And so I like to refer to it as sinking and sagging, right? So sinking involves kind of just the atrophy of various layers, both not in our just our skin, but also in the dermis and also the subcutaneous fat, and also the underlying bone structure, right? So as we age, we undergo osteoporosis, right, which is mineral bone loss. So that all gives you a deflating effect where things look gaunt and hollow. So you have to address that from whatever angle that you can. And by the way, um, talking about what we talked about a little earlier, the use of all the GLP-1 weight loss drugs have increased the incidence of atrophy and gauntness and hollowness in many patients,
Of
especially as
course.
they're losing fat and volume very quickly. So the second issue with aging has to do with sagging. That's things just simply become loose and wrinkled. And that has an intrinsic component to it, the intrinsic component just being the way we're genetically programmed to age, which that is a genetic blueprint that you've inherited from your parents, but also the environmental factors that we alluded to earlier that can accelerate the aging process.
Correct.
So let's talk about sinking first. So how
Okay.
do we address sinking? So sinking is addressed by restoring volume back. Now, in the old days when fillers didn't exist, what we all did was fat transfer,
Correct.
right? So we'd harvest fat and then we would inject it back into.
And it's had a renaissance again too recently. I mean, in micro and nano and all kinds of fat.
Great. So again, I would love to hear from you of what your thoughts about fat transfer are, because as you very astutely pointed out, there's been various kind of phases of fat transfer, and sometimes we discover things we did, and then people take a step back from it for various reasons, and now it's in fashion again.
Yeah.
But I think that you're probably much more of an expert on fat transfer than I am. Tell me what your thoughts about fat transfer are.
Well, I think that it's still pretty much the same. That we found out that you only keep about 15% of the fat that you use in autologous, or maybe less or a little bit more.
That's 1/5,
That's 1/5.
15%.
Yeah, 15%.
Very little.
Very little. So if you're going to use it, then you're going to need to redo the augmentation. The other modality is that it's gotten smaller and smaller in the size of the fat, into the point of destroying the fat cells themselves, and really using what they're calling the stem cells, or from that, injecting that combination of material, hopefully getting some scarring and some volume to that. So it's one of those things that it has lots of uses, because there's none of it really works real well, as you know.
Yeah. So, I always kind of like, in our field, stem cells have become a very trendy type of word to throw around.
Yeah.
Now, the FDA has issued a warning about doctors in the United States promising stem cells to be effective or curative for anything except blood dyscrasias or cancers of the blood.
Correct.
So when people talk about stem cells, like that we're able to harvest stem cells from the fat, can you, from my own knowledge, can you tell me what the evidence is that these cells that they're saying are stem cells? What is the evidence that we have stem cells in our fat?
Limited. I mean, and it's variable quality and quantity. So again, that's why it's not a reproducible process. So and you were speaking about your sagging and then your hollow.
Yeah.
So if you're using volume, what are you using?
Yeah, so then we get back to kind of, besides fat. So it's our fillers and biomodulators, right? So fillers, there's a vast number of hyaluronic acid fillers that we have for volume augmentation. And they all have various properties based on the density of the hyaluronic acid and the cross-linking. And so some of these terms are very common: Voluma, Juvederm, Restylane. These are all hyaluronic acid fillers. Hyaluronic acid is a major component of our skin and in our joints. It's a lubricant. We have fillers, hyaluronic acid fillers like Voluma, that the FDA has allowed them to claim that it lasts for up to 2 years, and it gives you a fair amount of volume. It's very good for volume augmentation of the mid cheek as well as the outer cheek. Juvederm, Restylane, FDA approved for nasolabial folds or lips. Then we have thicker fillers like Radiesse, which is calcium based. And there's some evidence also that Radiesse, having calcium, is also has some biostimulatory components to it, where the calcium particles are able to serve as a instigator for collagen formation,
Stimulant. Yeah.
stimulant or instigator for collagen for the formation. There's also Sculptra.
Yeah.
Sculptra is also considered to be a biostimulator. Sculptra is usually a series of injections, and gradually it restores volume back. It's made up of minced suture material, absorbable suture material, and so our body is also able to form a reaction to it in terms of creating collagen elastic tissue, and that's usually something that you do like once a month, and it's a series of injections. And I like to use that for people who are super hollow to naturally restore volume back to their skin. But all these biostimulators also need upkeep. You talked about fat transfer having 15% efficacy in terms of retention.
Yeah.
And so it's true also for these things that the fillers need upkeep, right? So even with biostimulators like Sculptra, you need to upkeep once a year or once every 6 months, depending how fast you metabolize the material.
So where does resurfacing come in, and the history of dermabrasion to chemical peel to laser back to chemical peel, then fractionated CO2, and then now Morpheus. Where does all that come in
Yeah.
in your armamentarium?
So that kind of comes back to the sagging component that we talked about, not sinking. So, you as a facial plastic surgeon, we know that the gold standard for sagging skin, especially on the face and neck, is a facelift.
Correct.
There's various, formulations of facelift depending how you do it and so on and so forth. But there are people who certainly don't want facelifts. They don't want the surgery, they don't want scars. So then there's this whole array of non-surgical procedures available, which are energy-based devices, whether it's lasers, radio frequency, ultrasound. These are all various forms of energy that at the end, the basic concept behind them, that they produce heat in your skin. And we know that our skin can easily be affected by heat in terms of contracting. You see that in the OR every day when you're doing your facelift or whatnot. When you are using your cautery, you could see that tissue that you're cauterizing to stop bleeding, what does it do? It contracts in front of your eye.
Absolutely.
We see that on a daily basis. Another very common example that an everyday person sees in their life, that proteins, which our skin has a major protein component like elastin and collagen, that proteins respond in a certain way to heat, is simply frying an egg. Now,
I was going to say bacon.
Okay, well, that's a good one too, right? But frying an egg, the egg white, what is egg white? It's pure protein, it's albumin, right? What happens to that egg? It hardens, it changes configuration. So skin has a helical configuration to it, and I like to say that the heat almost kind of tightens the spring a little bit, right? So all these things are heating up the skin. So not lasers, by definition, a laser is a beam of light. It's a monochromatic beam of light. That means it's one wavelength. And so depending on that wavelength has a certain tissue interaction with the skin. For example, you talked about CO2 erbium resurfacing. The main target for those wavelengths that the CO2 and the erbium employ is water. So that light beam has an intense reaction with the water in your skin, and the water is 90% of your skin, and it contracts the skin and it evaporates it. In terms of ablative lasers like the CO2 and erbium, it contracts and ablates or evaporates skin. In terms of non-ablative lasers, and non-ablative lasers are lasers that don't evaporate skin, but they rather coagulate skin. And those are non-ablative erbiums like the Fraxel laser. And the concept behind those is that the heat goes in your skin in a fractionated manner. It doesn't evaporate skin, so it doesn't have downtime in terms of raw and oozy skin, like a CO2 laser does or a deep chemical peel does. But rather the skin is intact, it's just red. and that is zones of coagulation in the skin that trick the body to create new skin around that zones of coagulated skin or dead skin.
Yeah.
So that's lasers. You talked about Morpheus. Morpheus is kind of a
Now,
name.
before I let you go there on resurfacing, is Fitzpatrick classification still the standard?
Yeah, so there's two Fitzpatrick classifications actually. The most commonly known Fitzpatrick classification is Dr. Fitzpatrick, who was a professor of dermatology at Harvard Medical School for many, many years. He's considered one of the founders of dermatology. And that Fitzpatrick classification goes from 1 to 6, and that has to do with the way your skin pigments and tans. So, for example, a very light-skinned person, like a Norwegian or Scandinavian type, would be type 1. Kind of the average European would be like a type 2. Like an Italian, someone like you or me would be a type 3 or 4. And then you've got brown skin color, somebody like, an Indian person or a light black skin person would be a type 5, and a dark black skin people would be type 6. It's important to categorize people to that because in terms of how safe it is for us to use certain lasers on different types of skin. So that has a lot of therapeutic implications for us to be able to classify them. That's the Fitzpatrick scale that most doctors know.
Correct.
And refer to. There's a different Fitzpatrick scale, and that's was developed by Dr. Richard Fitzpatrick, who actually happened to be my mentor, and I did my fellowship with him. He's the person that invented CO2 laser resurfacing, which is the gold standard for resurfacing for wrinkles, sun damage. And that laser, by the way, has had a resurgence.
Yes,
because
of course.
because of the advances we've had in CO2 laser resurfacing in the past 10 to 15 years. So I trained under Richard Fitzpatrick, and when he was doing his CO2 work, he developed his own wrinkling score because he was trying to figure out to classify the benefit that the CO2 laser gives you in terms of wrinkle reduction.
Correct.
So that's a different kind of Fitzpatrick score, and that's a Fitzpatrick wrinkle score that goes, I believe, from 1 to 4.
I see. Oh, I didn't know that. That's good to hear. That's good to know.
Yeah.
So again, you're using lasers. We were talking about, and then you're getting into penetrating devices like Morpheus. They even have the little micro-coring devices out now. I mean, will you have any ideas about those?
Yeah. So just getting back to lasers, we talked about resurfacing lasers, but I just want to say there's a whole vast science of lasers that treat other things in terms of the wavelength of the light, addressing a certain chromophore or target in the skin, right? We have vascular lasers that treat vascular things in the skin, whether it be vascular birthmarks, and I know birthmarks, you're very interested in birthmarks, especially disfiguring birthmarks in children.
Correct.
So we have lasers that treat vascular birthmarks, whether it's the pulse dye laser or the Nd:YAG laser. These are lasers where the wavelength of light, their perspective light, gets selectively absorbed by blood vessels or in particular by hemoglobin, which is red, which is a component of blood vessels. And that absorption causes selective heating of those blood vessels to destroy them in a very selective manner. Mm-hmm. I mean, these lasers have changed, revolutionized the treatment of birthmarks. Many birthmarks that were not amenable to any kind of treatment prior.
Absolutely.
We have lasers for treatment of pigmented lesions, right? There are birthmarks, again, I know that's your forte, pigmented birthmarks that are disfiguring, right? Whether it's nevus of Ota, or whether it's cafe au lait macules, or whether it's congenital nevi. So lasers have a role in that. Those lasers, the energy of those lasers is such that the energy gets selectively absorbed by pigment or melanin and causes selective destruction. There are devices.
Tattoo.
Well, tattoo removal is part of that process. The energy is getting absorbed by the tattoo. It's a pigment.
Yep.
Laser hair removal, the energy of the laser is getting absorbed by the pigment in the hair follicle of the patient's skin to destroy the hair follicle in a selective manner. Laser hair removal has a revolution as a treatment of hair.
Exactly.
Right? Before that, we were doing electrolysis.
Exactly.
We have now lasers for treating active acne. So we have a laser in our office called the Accure laser, where the target of the laser is the sebaceous gland or the oil gland. Now, traditionally, people always talk about Accutane. Accutane is the drug that targets the oil gland from a chemical point of view. It shrinks the oil gland chemically through a
Correct.
drug called Accutane, isotretinoin. We have a laser now where the wavelength of light gets selectively absorbed by the sebaceous gland or the oil gland, and it selectively destroys them. And we know that the oil gland is a major player in the pathogenesis or pathophysiology of acne.
Correct.
It's the overproduction of sebum that causes acne. But so lasers have really come a long way in the past 40 years. It's it's a whole new field in dermatology, and it's really a revolutionized treatment of many, many conditions. Getting back to skin tightening, Morpheus. So Morpheus falls in the category of radiofrequency. Radiofrequency, again, as a surgeon, you're using it every day when you're cauterizing. It's
Right.
really the same thing, right?
Absolutely.
That radiofrequency is getting converted to heat. It even sparks in your operating room. You see the sparks, as it's coagulating things, right? So what Morpheus is doing, or other radiofrequency devices previous to Morpheus, like Thermage, where it was a commonly, a household name, or other things like Thermitide or FaceTide or BodyTide. These all use radiofrequency. Morpheus falls in the category of RF microneedling, radio frequency microneedling. What this category is, there are devices that have a bunch of needles that come through, and the needle penetrates the skin and emits radio frequency. That radio frequency in the skin gets converted to heat and is supposed to contract the skin. Thermage was doing it transcutaneously, was doing it through the skin. It didn't insert needles in. Now, on the other end of the category are injectable radiofrequency, things like Thermitide or FaceTide or BodyTide, where you're actually inserting a probe underneath the skin, and that probe is connected to a device that emits radiofrequency, and that heat gets converted to heat on the end of your probe inside the skin. Those are considered to be the gold standards because you're delivering the radio frequency where it really needs to be in the deeper structures,
Yeah.
and you're really administering it in a very effective way. So yeah, they do play a role in skin tightening.
Well, you've given us a great lesson. In closing, what I want to do is have you reading an article the other day about AI evaluation of the skin, and then AI recommending which products you should use. What do you think about that?
Wow, that's very interesting. I actually don't know about it, but I'd love to see it, and I'd love to know what parameters they've plugged into the artificial intelligence algorithms to kind of evaluate that.
Well, that's one of the things we'll have you back and talk to us about sometime. Really appreciate you being here today.
Thank you so much.